So I'm now delighted and slightly surprised to introduce Michael Phillips, who's currently Director of the Suicide Research and Prevention Center of the Shanghai Mental Health Center, Executive Director of the WHO Collaborating Center for Research and Training in Suicide Prevention at Beijing Hulonggang Hospital. I bet you I got that wrong, I apologize. Professor, I did? Yes. The Professor of Psychiatry and Global Health at Emory University, Professor of Clinical Psychiatry and Clinical Epidemiology at Columbia University, Vice Chairperson of the Chinese Society for Injury Prevention and Control, and Treasurer of the International Association for Suicide Prevention.
Thank you very much, Mark. It's always a pleasure to talk about suicide here. Suicide often is the last person on the food chain in the violence area, but in fact, if you look at the World Health Report of 2002, suicide accounts for 49% of all violent deaths in the world, including deaths from war. So in fact, in terms of global health perspective, suicide is really a very important actor. Okay, which one? Okay, this is kind of the range of topics I'm going to cover. First, talk about some theoretical models, the best practice registry, which is registry that was talked about this morning, status of research, international perspectives, pesticide, which is really a core issue, and some integrated approach. So in all these areas, there's different theoretical models, and suicide is certainly has a whole range of theoretical models. The problem is that our interventions and our prevention steps depend on the theoretical models. You have a theoretical model, then you develop an intervention based on where you think those variables are related. And if you've got a whole different range of theoretical models, you're going to have different approaches to what's the priorities in prevention. Most of the models have been developed by psychiatrists. Now, there's public health people have some input as well. And so often individual psychological factors are sort of the center part of most of the models. Some take a longitudinal life course approach to understanding suicidal behavior. Still others give more important, kind of balance the individual and the social factors. But from my perspective, the current models really don't capture the dynamic nature of the suicide phenomena, as is true in violence as well. Cultures change, risk factors change, the relative importance of different actors in the world, in the environment that generates suicide change over time. So the idea that, as we talked a little bit about this morning, we develop one set of things that work. 5 years from now, they won't work. And we've got to kind of, that's part of the reason we need to keep monitoring the situation. We also have to be flexible in how we develop our interventions. This is one of the basic models of suicide called the stress diathesis model. It looks at suicidal behavior as sort of the interaction of stressors and the diathesis. Stressors being a mental disorder and some crisis, and then the underlying personality, hopelessness, and impulsive aggressiveness. And that can generate suicidal behavior. That's a very simplistic version of this particular model. This is another model looking at multiple contributing factors. And as you can see, if you're using different models, you can think about the intervention in different ways. So here they have biological factors, risk factors, neuroendocrine factors. Males are much higher risk of suicide in America. Predisposing factors, including alcohol abuse, personality profile, proximal issues, intoxication, hopelessness, chronic pain, impulsiveness, and then triggering factors. And so where are you going to intervene in this process that affects suicide? Some people, this is Eric Kane and colleagues at Rochester, have looked at individual cases and see over a life course, an individual's life course, these factors can kind of accumulate, and different levels of factors affect the propensity towards suicide over time. So he looked at, and that he divides into the classic public health approach of universal, selective, and indicated approaches. So personality factors that develop in an early age, and then there'll be substance abuse, have symptoms, may develop depression, hopelessness, and then sort of get suicidal intent, plans, and they actually have an act. So there's a progression, and this is an individual-based progression over time as the risk factors accumulate to actually generate the behavior. This is a model that is probably most widely used in terms of looking at prevention interventions, developed by John Mann and colleagues, published in the JAMA in 2005. And here, the list of types of interventions that are possible in this process that leads to suicidal behavior. So I'll go through them quickly. Educational awareness programs, primary care physicians, the people who often have the most recent contact with the individual who commits suicide, general public approaches, community organization, gatekeepers identifying high-risk individuals, screening for individuals at high risk, then treatment, those who have mental illness, pharmacotherapy, antidepressants, antipsychotics for people with schizophrenia, psychotherapy, alcohol prevention programs, follow-up care for people making a suicide attempt is the highest risk factor for completed suicide, so people have attempts are really supposedly high risk. Restrictions of access to means, and media reporting, because clearly copycat suicides is a real phenomenon, especially if a famous person commits suicide. You often get multiple suicides following that in the youth. So that's sort of a general perspective. Okay, so that's again, our theoretical models drive the locations we go to try and prevent. The best practice registry is, Jerry Reed talked about this morning. Jerry kind of runs it. It's on the web. It tries to identify interventions that have achieved acceptable levels of confirmation, that meet specific requirements that could be called evidence-based programs. This best practice registry includes 3 components. One, the listing of the evidence-based programs, those that meet the criteria of the National Registry of Evidence-Based Programs and Practices, and it's supported by SAMHSA. The second component looks at consensus statement by experts, so these aren't evidence-based, but this is what the experts feel really should be done to prevent suicide, and it works across all age groups. And then the adherence standards, this is for the American audience, adherence standards to the National Strategy for Suicide Prevention. So this is a list of all the programs that adhere to the policies and recommendations of the national strategy. So that's what's on the best practice registry. These are the 18 programs that have now achieved the status of being recommended because they meet criteria. In fact, of these 18 programs, 8 of them are in schools and 4 are in adolescents. So 12 of the 18 programs are focused on youth. But from a public health perspective, one has to think, what proportion of all suicides actually happen in youth? And I'm not sure the exact numbers, but I'm sure it's less than 20%. So we're putting 60% of our efforts, 80% of effort on youth and university students, and we understand why that is. But in fact, a lot more suicides are happening in other groups, particularly the elderly. Of these 18 programs, there's only one focus on the elderly, highest rates of suicide. So we really have to think about our distribution of our limited resources. And yes, we're concerned about youth, and it's a focus. However, more suicides are happening in other age groups. Of these 18 programs, only 6 have suicide attempt or a completed suicide as the outcome. Almost all of them look at, have they decreased suicide ideation, have they limited risk factors. So with these ability, even the 18 approved programs, only 6 really target the specific behavior we're worried about. Particularly ideation. Ideation in youth is very common. Its relationship to behavior isn't one-to-one. It isn't that determinative. Adolescent reports ideation. It's not necessarily much more greater risk of having suicide. So all these programs focus on decreasing ideation. Are they going to really reduce suicide? We don't know. So what is the status of the research? And of course, the best practice is focused largely in America. There's a couple of programs outside of America. Well, in terms of clinical research, several training interventions are based on the presumption that mental health clinicians can actually identify high-risk individuals. This is not the case. There's lots of evidence showing that we can identify a group of people who are at high risk, but we cannot identify an individual. So I know that a person with serious depression is more likely to suicide in the next year than someone who doesn't. But you give me 100 persons with serious depression, I have no way of assessing which ones are going to suicide in the next week or 2. You just can't do it. No clinician can do it. But a lot of these programs assume that clinicians can accurately predict who is at risk. You can't. There's a lot of evidence supporting that, but the programs depend on this. Most studies are too small or too short-term to show changes in suicide or attempted suicides, which are relatively rare events. And so these proxy measures, like ideation or depression, and their correlation to suicidal behavior isn't that clear. Antidepressants, we assume depression is the most common mental illness related to suicide, that's for sure, but the effectiveness of antidepressant treatment in reducing suicide is not definitive. There's a lot of studies, ecological studies, but it's a little unclear whether or not antidepressant per se actually reduces suicide. And then there's some evidence with youth that there's the risk of increased suicidal ideation in adolescents who are treated with antidepressants. Lithium, however, is definitely effective for people with bipolar disorder. That the evidence is quite strong. And there's some evidence that clozapine, one of the antipsychotic drugs, is helpful for reducing suicides in schizophrenia, but that evidence isn't quite as great. Only 4/10 of persons who report suicide attempts in high-income countries and 2/10 in low-income countries receive mental health treatment. So improving mental health services may not be a substantial effort, have a substantial effort on community suicide levels. So you can improve the services that are great, but nobody goes. In China, my country, 90% of people who make suicide attempts have never seen any mental health professional. So we can develop great service centers, but nobody's going to use them. And so the question is that really where we need to put our resources? The data on the role of improving and expanding mental health services is equivocal. So here are some of the psychological interventions that have been tried. The ones in the red are ones that are effective. Group therapy against treatment as usual, TAU. You see the numbers are small, and so a lot of these psychological interventions have been attempted. This is from the NICE guidelines. Might be useful, but only some will prove to be useful. And again, it's small targeted groups. Community-based interventions, again here, they often assume that the screening methods can accurately identify individuals at high risk. And there's a lot of question about that. Nevertheless, some brief interventions with high-risk groups, such as SuperMIST, which is a WHO-supported group in study in multiple countries of suicide attempters, do seem to reduce subsequent suicidal behavior. To help tell, the CHECK is a program for elderly where you kind of phone in with them and give them social support, done in Italy initially. School awareness programs, where a lot of effort has gone, gatekeeping programs, QPR, telephone hotlines, are largely of unproven effectiveness. Many countries, like in China, if you talk about suicide prevention, the government says, well, let's get a hotline. And so the idea is hotlines will reduce suicide. The evidence for this is very weak. This doesn't mean that hotlines aren't useful. I think they're useful for other reasons. But saying hotline is the way to reduce suicides, the evidence is equivocal at best. Comprehensive community-wide initiatives aimed at increasing treatment seeking for depression in Germany and the US Air Force study that was shown do show effect. And so programs that are multifaceted within relatively closed communities do seem to be effective. Means restriction methods, gun control. There's been a recent study in the UK of paracetamol, acetaminophen, Tylenol, controlling the size of the package that people buy them. So they can't buy a bottle with 100 pills, because if you take that, you're likely to die. So you'll restrict the amount that a person can buy, have proven effective. Other controls like car exhaust controls, pesticide controls, they're not yet definitive, though they do seem to be hopeful. Media-based interventions to decrease copycat suicides in some instances, specific instances, have been effective. For example, suicide in Vienna, there was a study where they limited reporting of subway suicides, and subsequently the subway suicides were reduced substantially. This is Institute Medicine Reducing Suicide National Imperative in the red. Currently available tools are inadequate to determine acute suicide risk or to predict when a person will attempt or complete suicide. You cannot do it. A lot of our interventions assume that well-trained clinicians or QPR people can identify those at high risk. It cannot be done. Okay, what's the international perspective? Well, as we've talked about already, and has been shown by the recent global burden of disease study that just published in Lancet a couple of weeks ago, 16% of suicides globally occur in high-income countries. 84% happen in low and middle-income countries. 95% of the research about suicide is in those high-income countries. Is that 95% of the research relevant for the 84% of the suicides that happen in the world? Probably not. And so we've been talking, how do you adapt? How do you move to the low and middle income countries? It's a substantial problem. So here's the 2009. Of course, there's questions about the data about suicide, but these are the relative rates internationally, where Asia, including China, have relatively high rates. And again, as I just said, 84% of all suicides globally happen in the low and middle income countries. Just to give an example, here in Korea over the last 20 years, there's been a threefold increase in the suicide rates. And their data on suicide is actually quite good. In China, over the same period, the suicide rates have dropped 50%. So if you know, these are countries that, both from Asia, it's hard to believe that the mental health rates in China have gone down 50%, and those in Korea at the same period have gone up threefold. So there's a disconnect between mental illness, mental health care, and suicide, which says, it doesn't say it's irrelevant, but it isn't the driving factor of the suicide rates. If Korea is going up threefold and China is going down 50%, it can't be just mental illness. And in fact, in studies in China, this is serious suicide attempters, 63% of women who make a serious suicide attempt do not have an active mental illness at the time. The Westerns, researchers say 95% do have a mental illness. So clearly, we have a very different context, and that's going to affect how you're going to try and intervene with these conditions. This is a study of a serious suicide attempt, asking people from the time you first thought of suicide, this is in China, until you actually acted. What was the duration of time? 44% said 5 minutes or less. Building up your mental health system isn't going to get to that 44% of the people. You have to do something else. So data from the low and middle income countries is challenging conventional wisdom, which has been generated from Western studies. Rapid urbanization does not necessarily lead to increased rates. China is rapidly industrialized urbanized in the last 20 years, but the suicide rates have gone down 50%. The heavy predominance of male suicides in the West, I say it's 3 to 1. Well, in China, it's about 1 to 1. In many Asian countries, it's a lot closer. So it's very different. Mental illness is not a precondition for suicidal behavior. It's important, but it isn't required. Whereas in the West, it's almost assumed that if you had suicidal behavior, you had to have pre-existing mental illness. The valence of risks and predictive factors, such as divorce and religious affiliation, are context and time dependent. For example, in most Western countries in Latin America, religious affiliation is a protective factor for suicide. In China, it's a risk factor. Chronic and acute stresses are independent. Specific life events, which can change over time, is less important than cumulative stress over time. Risk factors are largely additive, and pesticide ingestion is by far the most common method of suicide in the world. So there's tough questions for suicide prevention in low and middle income countries. Given the very limited access to mental health services and the reluctance of community members to use services, less than 10% of people with mental illnesses will use available mental health services. Is focusing on expansion of mental health services the best way to reduce suicides? Given the lack of country-specific evidence about the relative value of different interventions, how much should we depend on results from high-income countries to determine our intervention priorities? Now, we can't recreate the wheel. We don't have the resources to do all these evaluation studies. But what do? And that's a question of adaptation. Everybody talks, well, adapt it to what looks good, which might work. My point is that I think we need to do a systematic method of doing situation analysis in different countries, different settings. What are the available resources? And then see what can be adapted. Right now, it's well just adapted, but we need to be much more methodological and systematic in doing systematic situation analysis in each country to see the available resources, and then we can see what are the possible models that could be possibly adapted. So I think we need to develop the methodology of doing those situation analysis much better and being more effective and conscious of the way we do the adaptation rather than say, well, 1 or 2 people work in the area, let's see what we do here. We need to be a lot more systematic in that kind of research. How much of the effort should be placed in improving the quality of the monitoring system? Well, in many countries in the Islamic world, suicide is illegal. And so if you push the country to improve monitoring, they're just going to resist. They won't do anything. And you say, yes, we have to make an effort to make suicide, to remove suicide as an illegal act. But right now, that's the situation. So pushing them to do monitoring isn't the way to go in those countries. Given the disconnect between the level of intent and the case fatality, do we need to change our paradigms about identifying high-risk individuals? In China, a lot of people with suicide with pesticides, they don't intend to die. They're low-intent acts, but they're very lethal because the very lethal means the lack of good medical resources to treat pesticide ingestion. And so our idea of what's high risk needs to be rethought. What should the relative balance of resource allocation be in universal, selective, and indicated? And what role should means restriction play in the overall intervention package? So those are the questions. Okay, I'll come to pesticides. Pesticides account for 1/3 of all suicides in the world. The most common method of suicidal death is pesticide ingestion globally. In China, it's 58% of suicides. And it's also 29% of attempted suicides. So it's in fact, the overlap between completed and attempted suicides is quite great in China because sometimes you take pesticide and you might get to medical care on time and you might not, and that determines whether you live or die. Given the public health importance of this problem, we know surprisingly little about preventing pesticide-related ingestions. The characteristics, and also it's quite clear to me looking at low-income countries with large agricultural populations, in particular China, that what's driving the rates and the demographic pattern of suicide is not mental illness and mental health care, but it's pesticide use. As pesticide use goes down, as it has in China because so many people have moved to the urban areas, suicide rates go down because access to this very lethal means has gone down. But what can we do to reduce suicide from pesticide ingestion? Well, there's several approaches. Banning the most toxic methods. It's usually category 1 organic phosphates. Decrease access in the home. Community education about the lethality. And improve training to increase the access to necessary drugs and treatment for rural primary care providers. Does this work? Well, a lot of people think if somebody is determined to suicide, they're going to die. The fact is, many suicides, not only in developing countries, but also in high income, are impulsive. People are very ambivalent when they're thinking about this. This is an example from Sri Lanka. Control of that category 1 pesticide resulted in a dramatic decrease in suicide rates. And it says, well, is there going to be substitution? Sometimes there is, but often the substitution will be much less than the original rates. This is from Sri Lanka. The WHO has had programs for safe access. For clinical management, this WHO programs have been involved in. Typically, in at least this is rural China, pesticides are stored sort of under the sink, sort of in the household, easily accessible to anybody, including children. One of the programs that we're developing are boxes, lock boxes for the use of pesticides. And we've done a large project in China. Another one's been done by Keith Houghton in Sri Lanka. It's not yet finished. And so this is a lock box. You put it up on a high place on the wall in the home. This is a study we've done in Shanhai province. We supplied 11,000 homes with these lock boxes and compared it to other communities. And this looks at the results down in the yellow. Suicide rates over 2 years. Completed suicide decreased by 63%. The comparison counties decreased by 30% because there has been an overall drop. But clearly this is a dramatic improvement. In fact, if you look at the details, people didn't lock the boxes. Only 20% of the people did what we wanted them, lock the boxes. But they had the boxes, they put the pesticide in the boxes, so overall the program appeared to be pretty effective. Is this worth it? Well, there are 3 different inventions, and this is a projection, restricting access in homes, banning the most toxic methods, and improving access to the quality of medical management. If they were only 20% effective, if each of those 3 programs were only 20% effective, we would save 60,000 lives a year in China alone. That's almost double the total number of suicides in all of America. And that would be $1.7 billion. That's pretty cost effective. Okay, integrated approaches. There's been a large program that started in Germany, the Nuremberg trial, which is now expanded to the European Alliance Against Depression. And this is a very comprehensive program that worked with primary care doctors, that got sports personalities to talk about depression, get people to utilize services, a huge media campaign. And as part of this, they had a dramatic reduction in suicide rates over the years that they implemented the program. Now this has been expanded to the European Alliance Against Depression. So these very comprehensive community-wide programs appear to be effective. The WHO is trying to do a similar thing in rural areas of developing countries and is included as part of the mental health gap, suicide and self-harm. Whether or not this will be effective needs to be tested, but the WHO is included in an overall comprehensive package for mental health. My own take is that no, in developing countries, we cannot spend all the resources to do all the detailed studies we'd like to do, and we need to promote national plans. And under those national plans, we will try to collect what data we can. But the urgency and the it's just saying, well, you got to get data before you can do anything. One, as we said before, the politicians aren't going to buy it. And two, you need to have a structure that supports the overall effort, including the research. And this is a proposal I've been trying to promote in China for a number of years without much success because the rates are going down and the politicians say, why do we want to do this now? They're already looking good. And so that's the disadvantage of being successful. But this is very comprehensive, starting from resilience in children and going up to mental health services and means restriction. Thank you very much for your attention.